Okay, wonderful. Welcome, everyone. Thank you very much for joining us today. It's my great pleasure to welcome all of you to the 9th webinar in the series on ethics and COVID-19 on behalf of the Milken Institute School of Public Health here at George Washington University, and especially the Office of Research and the Bioethics Interest Group. I'm delighted today to welcome you all, and including our panelists, for an exciting session on digital privacy. Ladies and gentlemen, as you all know, COVID-19 has put us in a situation where many operations and processes that used to be face-to-face, that used to be in a room or in a building, are now taking place over the internet, on the web, on electronic media. And this includes things that we did generally for healthcare. For example, looking and talking to our physicians. It involves things that we did in terms of administration, in terms of approving paperwork and processes, but also in terms of research and in terms of interacting, not only with each other, within professional groups, but also with our research subjects and so on. And so now this issue of how do you maintain privacy, confidentiality, anonymity, and what are the new realms into which this exploration, particularly as we not only have audio, but also video. And what can you see, what can you hear that you ought not to see, that you ought not to hear, that may impose risk, that may impose additional burdens. These are the types of ethical issues that I hope, together with our panelists, we will engage in an exciting discussion. I'm really happy to welcome all of you from around the world. Thank you for many of you for joining us. Many of you have become regulars in attending these webinars. We are so delighted and pleased and really happy for the support that we get from not only here at George Washington Universities, but also several of the research grants that we have, including our training grants from the Fogarty International Center at the National Institutes of Health here in the United States. I'm really excited today to welcome our panelists. I'm honored that we have a mix of a GW expert and a non-GW expert with us today. And I'm going to introduce them in 1 minute. I just want you to make sure that, again, for those of you who have colleagues and friends in the waiting room, as I see some people, please tell them to identify themselves very quickly so we can get them in the space as well. Today, I'm excited to welcome our first panelist for today, Professor Ross Upshur. Professor Upshur is a professor in the Department of Family and Community Health. He's actually Division Chief of the Division of Clinical Public Health at the Dalla Lana School of Public Health at the University of Toronto. I have followed and admired Ross's work for many years in the field of global bioethics. Highly relevant to our discussion today is that Ross is actually the co-chair of the World Health Organization's working group on ethics for COVID. So we really hope that we will indulge in a little bit of some of the latest thinking that he's been involved with. And for those of you who are joining us from multiple different organizations around the world, Ross also has been on the board for Doctors Without Borders and also on the Gates-funded Grand Challenges program running out of Canada. So Ross, thank you very much for joining us. Excited to have you, and over to you for some opening comments on this topic.
Thank you. It's a great privilege and pleasure to be with you this afternoon. I know some of you are in different time zones, so good evening if it's the evening, good morning if it's the morning, wherever you will be. So I'm just going to bring up my slides. So again, thank you for this opportunity. It's a great honor and privilege to be with you today. As noted, I am a Canadian, and Canadians are known for their being polite and apologizing. So you know you're in the presence of a Canadian when they say thank you to the ATM or apologize for anything. So this is my omnibus apology slide. So if I mislead you, if I bore you, if I don't cite your favorite theorist, if I'm off point, I just apologize for everything in advance, and then I can get on with what I want to say. So one of the interesting things I want to discuss is, the COVID-19 response. Does it raise actually unique issues with respect to data privacy. And I think that one area in which it really does is on ethical issues in public health surveillance. So some of the previous work I was involved with we're coming up with ethical guidelines for public health surveillance with the World Health Organization. And I remember at that time we had quite a spirited and it was a lengthy process to get the document, and you can find it on the WHO website. But I thought we stopped short. And we stopped short because we didn't engage with the new realm of digital technologies, with smartphones, with, you know, using, for example, in Canada, we had an outbreak of a foodborne infection sort of figured out by looking at those kind of privilege cards being scanned so you could find out who was buying what. We didn't deal with things like facial recognition software. And I thought, you know, we were still a bit in the 20th century, but I think COVID has forced us into the 21st century. So I'm going to actually focus a little bit about new technologies in a public health emergency, raise some questions around regulation, oversight, and evaluation. I may not be as definitive as you would like me to be, but I think at this stage of the outbreak, being provisional and humble and are probably virtues. And I'm going to focus on proximity tracing apps, because that's a document that we worked on. So this came out as an interim guidance. It's available at the World Health Organization website. And it was about the ethical considerations to guide the use of digital proximity tracking technologies for COVID-19 contact tracing. Everybody's aware that apps are going to be used, and it actually distilled in the framework of principles that we elaborated, I think, a lot of the thinking around digital privacy and public health. So one of the points of departure here is that in the international health regulations, which are kind of the master document that the World Health Organization has at its disposal, that all member states are signatory to, though many have not actually brought their health system up to compliance with the IHR, but they do have to develop public health surveillance systems that capture critical data for their COVID-19 response. But they have to ensure that these systems are transparent, responsive to the concerns of communities, and do not impose unnecessary burdens, for example, infringements on privacy. How germane for our topic of today. So ethical and social political issues are raised by these new technologies, and many of them sort of distill or constellate around standard concerns about consent and respect for persons. But now that with the need to actually respond in a convincing public health manner to bring the outbreak under control, there's an additional need to balance concerns for public health and public good. One of the interesting and striking things that we found in this work, of course, is you need to recognize a heterogeneity of culture and cultural practices. So how people actually view privacy, what they think falls under that umbrella, what they think is happening when they use these technologies. As you can see, I'm an older man, but I have younger children who I consult regularly on all matters of digital technologies. And so in preparation for this, I asked them what they thought their view was around digital privacy and how much they felt comfortable governmental agencies knowing, or if they signed up for an app, what would go to a commercial vendor and what would go to the government. And I think there's a need to strike those balances. But there's also, we have to be clear that there are many regimes that do not uphold and respect human rights. And the concern with the use of contact tracing and proximity tracing is that governments would use the surveillance data for more than just surveillance of COVID-19. They might in fact use this as an opportunity to extend their power and normalize these kind of use of apps and access to the information. So we had quite a vigorous discussion around that. And of course, there's very few countries that can actually develop an app, implement it, and get it out without the assistance of the tech sector and private industry. And as probably everybody knows, some of the major tech companies were coming forward and saying, yes, we'll be happy to help you with a proximity tracking app. And then you raises the question of, why are we doing this in the first place? Is it merely for an individual to know about their risk, or is it serving a public health goal? And how you think about balancing these interests will tell you a lot about what the intention and purpose of the app is. And not unsurprisingly, like every other dimension of our response to COVID, there's not just one app, there are multiple apps, and some people are developing them amongst student groups. I'm sure there's a group at your university that was very keenly involved in the development of one. So just like vaccines, of which we have now over 100 candidates, therapeutics and diagnostics, there is a multiplicity of these digital interfaces, and the regimen and the way we're going to figure out whether they're actually effective or not hasn't been established. That's a really big concern from a public health effectiveness point of view. So how do we manage these trade-offs and conflicts that arise just even contemplating using something like this? And of course, like everything in this pandemic, there is no easy solution, largely because we don't have proven or demonstrated effective practices that will guide us, particularly in the use of apps for contact tracing on a large scale. So some of the things that we recognized is that there had to be some preconditions in place, that there had to be some sort of data protection legislation and oversight in place, some small modicum of trust in government and the public health there, and a requirement to have community engagement. And I'll come back to that towards the end of my introductory comments. So in the document, we outlined several principles. Some of them are more ethically oriented, some of them are more technically oriented. And that's one of the interesting things about the work with the World Health Organization, is that we've been trying to integrate ethics into the technical guidance documents. Historically, ethics documents set out aside from the technical considerations, which meant that people who were actually responsible for the implementation of programs didn't have the ethical considerations at hand, and when they ran into problems in the field and on the ground, they would have to kind of kludge their own solutions because the ethics wasn't integrated. So I'm going to briefly, I'm not going to talk in depth about all of these. As you can tell, it's a classic committee document. Whenever you try to trim down the number of principles, we had to keep expanding them. But some of those you can see are fairly technically oriented, and some of them are sort of more classically ethically oriented. So the ideas of testing, and I'm just going to highlight a few that I think are important, and then there's two key ones that I really want to come to. So the issue of time limitation is that this really be understood as something that is for the pandemic and only for the pandemic. And then once it's over, it's over. And this links over to this notion of limited retention of information, because we had quite an interesting discussion that it might be unethical to actually delete data when there would still be potential research questions that could be answered in some form of anonymized manner. But for the ethics point of view, the notion of proportionality was probably key. So one is that this notion, and I think maybe Melissa might speak to this, because is that this notion that it's justified by law, that there is a legitimate public health purpose that's being obtained by its use. It's suitable to achieve the intended goal. It's necessary, and it's reasonable and proportionate to the aims pursued. And the goal here, of course, is that you're going to use the least intrusive or privacy preserving measures should always be preferred in an app's design, including avoiding the use of physical location and tracking. The other issue that I think is we wanted to make sure that, collect the least amount of data possible, that there be restrictions on use, that is, that advertising and commercial interests have a limited access to it. The voluntariness one is going to be very interesting, because certainly certain people entering countries and certain jurisdictions, if you don't sign up for the app, you don't get to come into the country. I'm actually going through that with my youngest daughter, who's going to graduate school in another country. And she's welcome to come in so long as she goes into quarantine for 14 days, downloads the app, and adheres to all of these. So there's no voluntariness there whatsoever if you want to come and do it. So it's sort of a conditional. The issue of transparency and explainability is just going through in a sort of user-friendly way all of the different ways in which the data is going to be used. So mindful of time, security is rather sort of straightforward, that it's used for infection, you know what the tracking, that it's accurate and accountable. But one of the big important things, and I'm not going to read through all these bullet points, was this notion of an independent oversight. And I think there's actually some room for very innovative thinking. So I can speak to my own jurisdiction in Canada. We have a privacy commissioner who's generally in charge of the evaluation, enforcement, and monitoring of health information privacy. And I think the idea of an independent oversight would be something that would not necessarily simply be a privacy commissioner, but something that would look at the broader impact of health technologies that have implications for privacy that relate to health, that could then have a kind of multi-stakeholder component to it. So you're independent of the government, you're independent of public health, but you have the obligation to actually make sure that these principles are adhered to when they're implemented. So that would mean that you would be looking at agreements, you would be able to look at clauses, you would be able to access the information, and like the last one at the end, that you would be able to ensure that it was done fairly and that there were no egregious violations of either an exploitation of vulnerable or marginalized communities, or for that matter, political enemies. And finally, this notion of civil society engagement, which I think is really important. I've just bolded one point that you know, the data collection efforts should include free, active, and meaningful participation of the relevant stakeholders, such as experts from public health, civil society, and the most marginalized groups. So we thought that this participatory approach to these digital technologies, particularly for the impact on digital privacy, would actually enhance buy-in and voluntary participation, compliance, and also build trust. So I'm going to stop there, and there's much more to be said here, but I was asked to be brief, so I shall stay brief, and thank you for your time, and I will hand it over to Melissa.
Well, thank you very much, Ross. I really appreciate that very nice summary, and thank you for focusing on one aspect, the new technology aspect, and reminding us about what you call heterogeneity of culture. We'll try and come back to that and what that means, but also a reminder in trust of the political systems. And this is really, really important. And I really like the example right at the end you said was a Canadian example of a privacy commissioner. And I'm wondering in how many contexts that might work. So we'll come back to some of those issues that you've raised. Now I'm really delighted to welcome my colleague, Professor Melissa Goldstein, who's a professor here at the George Washington University's Milken Institute School of Public Health. She is in the Department of Health Policy and Management, but really has been looking and teaching at these issues for many, many years, including ethics of health information technology, health information privacy, and most recently on things like ethics of big data. So Melissa, thank you so much for joining us today, and over to you for some opening reflections on this topic.
Thank you so much, Adnan, and thank you, Ross. It's great to meet you, and not surprisingly, I had planned to discuss many of the same things that you discussed, but possibly actually from a different angle. So I am sharing my slides now. Let me know if anyone has trouble seeing them. Before I get into some details, I thought I would mention as background information for all of us to think about during this discussion and in the Q&A session after I do a few minutes of intro. The difference in the World Health Organization as essentially an advisory body and in individual states who may or may not be members of the WHO, as we've seen ourselves lately, right? Ourselves being the US, and the legal systems of the various countries, right? So Canada has a different legal system than the US does. For instance, we do not have a privacy commissioner in the United States. Another example is the United States is a signatory to the international health regulations, which Ross mentioned, the IHRs, but we do have a restriction on signing on to those. And the restriction is based on the fact that we have a federalist system of government that relies both on a federal government and state governments. And the federal government in the US relies on data being provided by the states. And our agreement with the IHR is, well, the federal government can't give data unless the states give us the data, right? So different countries have different setups this way. And so it's important to distinguish when you're talking about the laws of a particular country versus advisory bodies and guidance and ideas that perhaps all countries might believe in, but execute in different ways. So I will get into some nitty gritty here. So I actually have, I am a member of a federal advisory committee called NCVHS, which stands for the National Committee on Vital Health Statistics. We make recommendations for the Secretary of the Health and Human Services Department at the federal level. And I borrowed some of these questions for us to address from a meeting that we had on June 17th. And this is the link to that meeting, and you can find the full set of slides there. And many of these questions dovetail with what Ross said, but perhaps from a slightly different angle. And this is focused on purely domestic law, ethics principles, but with a focus on how do we implement it here in the United States. So first, what should happen with data in an emergency? Is it different, which Ross actually mentioned? Is it the same? What are fair information principles for a pandemic? Fair information principles are general principles, many of which Ross mentioned in his principle list, but they're not exactly the same as implemented here in the United States. What data should we be collecting from the first instance? Should it be location data at all? And I have a case study we can look at in a few minutes to discuss that. What rules are okay to override to advance the public's health? And what should remain in force and perhaps inalienable? Never change, ever. As absolute as we can get, which of course we don't ever get really absolute in principles. There are always exceptions. What level of identification of data is appropriate for what purpose? When is there a need for identifiable data? Sometimes we actually need identifiable data, but many times we do not. And we need to distinguish in collection purposes and use purposes between those cases. When is aggregate data more appropriate? And is case level data without identifiers an adequate compromise for the uses that we need in public health in general and in an emergency in particular? And here we go again. Do our standards differ at the local, the state, and the federal levels? Think about the conflicts that we've seen in various states between cities, mayors, governors at the state level, and the federal level during this pandemic. There are conflicts evident that we've seen in real life over the past 6 months among all of these levels. The data that they're collecting, the data that they're sharing, the data that they want, the data that sometimes they're actually fighting over. So these, there are some big questions here. Once collected, where may the data get disclosed? So there could be a governmental body collecting the data. It might be a private entity collecting the data. For what other purposes, if any, should it be used? How long can we keep it, which Ross talked about, time limitations, and what guardrails do we put in place so that we don't misuse the data for other purposes? And here I've got some big, hot topic purposes: law enforcement, immigration, other purposes that actually undermine trust in the public health system. If we need this information and we need to use it for emergency purposes in the case of a pandemic, and this pandemic in particular, how do we protect it? Is there any way to protect it, or is there always a chance, a risk that it's going to be used for these other purposes? And are we willing to risk that chance And if we're not willing to risk that chance, it may mean not collecting the data in the first place, which a lot of people have a lot of problems with that. Because if you don't collect the data, you can't use it at all, and we'll never know. So the case study I mentioned, just for thought, if researchers, federal or state agencies receive home addresses or neighborhood zip codes, zip code level, right? This is pretty specific. It's not, it's not your name and social security number, but it's very specific to location. Data of persons who have tested positive for COVID-19 in the past 60 days, what issues might arise? And remember, this is only people that have tested positive. So it's a particular set of people, and it might indicate where they live. It could also indicate where they most likely travel, going to work, where their job is, things like that, because we have associations between that. So think about these ideas as we go forward. So issues for consideration. These are those specialized technical issues in the New World Order. Now, I may not be the same exact generation of Ross, but I remember when mobile apps didn't exist, right? So this is somewhat new to most of us. Contact tracing mobile apps, location data. Now, remember, Google and Apple working together to set up systems to do this and selling or donating what they came up with, different countries or in the United States, to private entities and or government. And then after it was worked out, we realized, you know what? They're not perfect from a privacy and security system either. And they might be our best paradigms of people and technologists who know how to work on this. As Ross mentioned, there are different contact tracing apps in different countries. Some of those countries have been extremely successful. For instance, Taiwan, South Korea, and actually tamping down on the pandemic. In other countries, we've seen a lot of controversy among the populations about actually using these apps. In Poland, for instance, there are big protests, there have been protests about actually using the app, how long the government keeps the data, things like that. So we've watched the examination of governments using this type of apps, requiring this type of apps, as Ross mentioned. We haven't actually implemented it on a government scale here in the United States, or a legal requirement here in the United States, but there are people who are using privately developed apps. Very recently in the United States, July 10th actually, HHS issued new guidance. HHS is the Department of Health and Human Services on the federal level, that we're switching data collection from hospitals from the CDC, which is where it's always been, the Centers for Disease Control, directly to HHS. I'm going to mention this a little bit more in the next few minutes because it's become extremely controversial. Next, the need for identifiable versus de-identified data, which I already mentioned. And then third, these buzzwords, which Ross already mentioned too. Syndromic surveillance, meaning surveillance on a very wide scale, preferably in real time. What is happening right now? Many of you might have seen Google flu trackers in the past, right? Who's got the flu where? So this would be who's got COVID-19 where? And you see maps every day on the New York Times website, on other websites, about number of cases, where the cases are going up, where the deaths are going up. Syndromic surveillance is the idea that we can act on this data in real time, which we can implement to a greater or lesser extent. It's not perfect. Many of them, sometimes many of us think about these technical and digital methods for data collection as perfect compared to the old paper way. They might be massive improvements, but nothing is perfect yet. So we also need to remember that. The idea of data mining, which is massive databases of data. So we're gathering more and more and more data. And the idea is that we can use different artificial intelligence and machine learning platforms to learn from that data. I read an article yesterday, or maybe this morning, in Stat about, all right, we've got all of this data, but what does this data tell us? Does it actually represent what we're hoping it's going to represent? Does it represent people getting sick or people getting better, what does it represent? So this is the topic of growing importance, the COVID-19 guidance for hospital reporting, which you can see the entire guidance there in the link. State attorneys general, I believe 22 state attorneys general have written a letter, and I've got a quote from that I'm going to show you, expressing concern about this switch from the collection of data going to CDC now to the collection of data going straight to HHS. There also has been proposed legislation in the United States Senate addressing this guidance and proposing to reverse it, to undo it because of the concerns with it in the Senate. And this is a link to the proposed legislation. And here's a quote to tell you a little bit about what the issue is. The new system puts hospital data in an entirely separate system than nursing home data and places critical information about hospitals, patients, and the spread of COVID-19 in the hands of private contractors, not government agencies, without the assurance that it will be protected and that public health authorities and researchers will have full access to the complete data they need to continue their vital work. Now, the idea of protection is that even local health departments, state health departments, the CDC have a separate set of regulations that protect data, that anybody who works within those government systems has to agree to and abide by to be a person working in those. So if any of you who are current students actually do an internship, say at a local health department in a county or here in DC, in Maryland or DC or Virginia, you have to abide by the regulations of that local health department. When we have private contractors who are holding the data, there are different laws that apply. The public health regulations do not apply. There might be privacy laws that do apply depending on who those private contractors are, but they're different laws, and many people are very worried about that. So essentially what I've done is give you a bunch of questions and issues to freak you out, but not give you any answers, but we'd like to have really a full discussion of these ideas and others, because this is happening right now.
Thank you very much, Melissa. This was great. I think, your reminder, and thank you for reminding us of your membership of the National Committee on Vital Health Statistics and the Fair Information Principles. And I think many of the questions you raise, I'm sure we could have a webinar for each one of them. But we do have a few minutes now to throw open the discussion. Please, if you have questions or reflections for our panel, please put them in the chat board. I, together with Hina and I, have been monitoring this, and I'll direct some of these questions to our panelists. Let me start with you, Ross, because you mentioned very specifically this notion of heterogeneity of cultures. And then we have some statements that are asking about cross-national comparisons of how information is treated. Could you talk a little bit more about that? Do you really think that this has to be so specific that every country has to develop their own rules, or is it the exact opposite way where everybody can believe in some fair principles?
Well, I think what will happen is, regardless, we will find out that each country, and even within countries, they're going to develop their own approaches. They may not get up to the weight of regulation or law, but people will behave in ways that they think befit their culture and their interests. So, it's quite remarkable when we were putting this together, these principles just on one limited facet of an obviously complex and hydra-headed aspect, all of the digital privacy issues. So it was clear that certain parts of the world were more than happy to have security over liberty, and other people were much more preferable to having more liberty and say and control over their own information and where it goes than others. So that tension was there, and that we didn't actually resolve it entirely, and that's where this notion of independent oversight, which could be universalizable, right? If you had some sort of independent oversight within each of the member states. And I'm mindful, I saw some of the comments raised about, well, what do you do in situations where you have complete distrust in the government and no really good indication that the government's going to take your welfare seriously or uphold your rights to that information. And that's where I think civil society organizations can play a witness role and actually use mechanisms to bring those to the global consciousness. So it was interesting because Amnesty International was at the table, and they were very clear about their concerns about how these technologies could play out in certain jurisdictions. Interestingly, Melissa, you mentioned the federalism problem in the IHR. Canada has the same problem. Everybody, I know there's a large number of Americans at this meeting who think that Canada has a healthcare system. We don't. Each province has its own healthcare system because health is a provincial responsibility. And the same thing with data forwarding. It goes to the federal government only by virtue of the grace of provincial authorities. So we can't have an easy adherence to the international health regulations. So I think there's going to be one of the things at the global stage is to accept the fact that there's cultural difference and try to find, and legal variability, and try to find means that would allow that to be tailored. And that's where this independent oversight mechanism came into play.
So Melissa, I'd really like, I want to continue this issue about trust, because we see that play in many of our low and middle income country situations in this pandemic. We saw it in high income country, and we saw it right here at home, and we are seeing it every day. So talk to us a little bit about, in the context of this mistrust, how do we discuss some of these issues?
Unfortunately, trust has actually been a large issue in this country and in some other countries, but I think maybe less so during the pandemic. And you can see that in the protests and in the dissent that we see about things like wearing masks in public, about not congregating and have big parties, about insisting on having private parties, even an insistence on sharing information with local public health officials about who was at those parties so that they can then conduct contact tracing, right? And follow up to try to help the other people. I think a lot of people have felt that the public health authorities have given mixed messages. At first, they didn't say we needed masks, and then they said we do need masks, so what do they know, right? And when we really have a science that is progressing, and we really have a pandemic that is progressing and changing, and that the scientists are actually learning as we go along, which means we can't possibly get everything right the first time. And I think trust is always an issue. Giving your data to a government requires that you trust in the government to handle the data correctly. And because of the way that we've had this discord between local, state, and national levels, I think it's gotten even worse now. And it's very sad to those of us who really believe that the government is trying to do the right thing, right? It's a very sad state of affairs, because public health depends on trust. And we're not going to get anywhere unless we earn that trust. And that's up to us to earn it, so.
No, thank you, Melissa. That's very important. And we'll come back to this. But Ross, you, in your, one of the examples you gave, this notion of a privacy commissioner, or this notion of an independence panel of sorts. Talk to us a little bit more. How do we ensure this independence? Who are these people? Are these non-government people? Are these people who've declared their independence? You know,
that's right.
How do we ensure this?
Yeah, so you have to trust that the independent people are actually independent. And we're in such an eroded area of trust that you can't even trust that people who say they're independent of the government are actually independent of the government. So there's kind of a meta-theoretical problem there. So what we have in Ontario, which I can speak of because that's where I live, is we have a fairly strong health information privacy legislation. And there is a commissioner, a privacy commissioner, who's responsible for ensuring that governmental agencies and others adhere to those standards. They have powers of inquiry. And they have actually, so, you know, this is an interesting issue. So I usually teach this when I teach research ethics, because when scientists ask why is it that they have to encrypt their data, they can't just keep nominal data on their computer, or it's because, you know, somebody had a laptop with nominal data that gotten ripped off in a car. That's actually how it started. As a colleague of mine had his laptop stolen. He had personally identifiable information on that. I'm pretty sure the thief had no interest whatsoever in that data. They wanted the computer. But because of that, the privacy commissioner then instituted standards in research institutes that all data had to be, you know, encrypted and behind VPN. So they actually have the power to insist upon standards that uphold privacy. I think that it would be interesting to have a health information panel or a public health information commission. Again, it depends on what kind of a state you're in that could actually strike these organizations that would then be able to have multi-stakeholder process. You would have people who are involved in researching with the data, you would have civil society organizations, you would have people who represent communities that are usually marginalized or differentially affected, and they could then set policies in place to sort of monitor the use of these technologies. I'm not aware of any jurisdictions that have those as yet, but because there is this tension in our group between whether that information should be held by a governmental organization in the first place. And again, it speaks to what the purpose is. If it's merely to let individuals know that they may have been in contact with somebody, that's one thing. You can completely unlink these proximity tracing apps from any public health purpose, because if public health agencies are not given access to the data to do the contact tracing and follow-up, then these apps are merely serving the purpose of private individuals. They're not serving a public health goal.
Yeah.
And many of us strongly felt if you're going to invest in these technologies, they should have a public health goal.
Right.
But then where is that data going to go? And should it be held by the companies, and then they get the metadata and they can trade that and make lots of money? And then all of these need to be negotiated. I'm not sure anybody's got it right yet, but that's the idea behind that.
No, I think that's absolutely correct. And this is not the first time public health has thought about the notion of independent panels and community engaged panels and so on. But I feel that, and I think Melissa said this, and Melissa, you know, based on a couple of the comments on the chat board. So we have a real issue here, because if you have a problem of trust and you can't believe that the information is going to be used just for good, but may also be used otherwise, do you not collect it in the first place? Which would be a huge opportunity lost maybe, because then you would never have the chance. So what's that trade-off? What's the tension there?
So among the fair information principles, which we lovingly call the FIPS, right? So among them are both collection limitation, that you really only collect the data that you need. So, and that would be the minimum amount that you need. You don't just say, give me all of the information that you have. You ask the information that you need. Now, for contact tracing purposes, that may mean your contacts. It may mean where you live and where you work, so that the travel. So you may actually need data that has privacy or security implications. So you collect that data, but then you also have a purpose specification. We are collecting this data for this particular purpose. And then from the FIPS perspective, you only use the information for the purpose that you said you were going to collect it. So to build trust, you say, look, populace, look, community engagement people, please go back and tell your people that we want this information and that we are required by law only to use it for a particular purpose. And then if we use it for a different purpose, then we are going to suffer the consequences, that there are remedies for this in law, and that we are accountable for doing what we said we are going to do. Now, there have been voluntary agreements by private companies. There are some requirements in law, for instance, HIPAA, but of course, HIPAA only applies to certain entities. It doesn't apply to everyone, and generally it doesn't apply to mobile app developers. So some mobile app developers have agreed to abide by these principles on their own from a voluntary compliance standpoint, but our laws generally have not caught up with this idea of this limitation. We're only using it for the purpose that we said we are, and that we are not going to re-identify data that has been de-identified, meaning that we don't know who the person is, but you make an agreement that you're not going to dig into it and do fancy technology solutions to figure out how the person is, who the person is.
Yeah. No, that's great. That's great and very, very complex. So one of the things that, we haven't touched upon, but I'll use it to make my next segue into, and maybe back to you, Ross, is there are so many vulnerable populations, right, during this pandemic that have always been vulnerable, whether it's in the context of a global community, the poor, those who are urban, living in urban slums, in the US context, African-American population, minority population, but also children. And when we think about digital privacy issues, children and their data is important. So Ross, have you at the WHO committee thought about the data of those who haven't touched the age of 18 as per UNICEF's definition of children, and knowing that legal statuses differ across countries? Talk to us a little bit about.
Yeah, so it was raised but not resolved, largely for the reasons that it's complex, because nothing's, mature minors, as we would say, and actually lots of kids have in high-end and around the world have access to these devices and can freely download apps. And it's the same behavior whether you're younger or older. You never actually, you just click I agree and off you go. I think very few of us actually have read through all of the small print. It's perfectly transparent. Everything you need to know is in there. It's just 67 pages long. It could include, the rights to all of your future earnings or your left kidney, for all you know. You've signed that away and given your informed consent to it by saying you agree. So I think that that some of the issues about what people would want children to know and what sort of protections would need to be in there are evident, but there's actually, it's so gameable, some of the, particularly in the digital privacy era. So for example, you can go to a website and it says, are you over 18, yes or no? And you could be 16 and say, yeah, of course I'm over 18. I really want to get behind that next frame to see what's there. So I think the issue of digital privacy and childhood and children is a very tricky one. I don't have any definitive or clear answers to that because I think it's still an emerging issue.
Yeah, and Ross, to be honest, I mean, we could replace the word children, for example, with a vulnerable group, the poor, the marginalized, and so on, and the level of mistrust increases, particularly then in those situations, and so. It sort of emphasizes this, which I suppose, Melissa, brings me to another point that has been raised, and I think you actually touched on that, which is, should our framework for this be the short term, that is, this is just for the pandemic, or are we trying to use the pandemic to create new systems? I mean, of course, the positive side could be that we help improve them, but the negative side could be that once entrenched, governments and not so friendly governments could have more access to them. So how should we protect the community, or what other safeguards could be put in place?
It's a very difficult and interesting question, because the pandemic is not the only public health emergency that we have faced or that we will face. And they could come about in various circumstances. For instance, a natural disaster. Think about Katrina and the number of people who had no medications because their medications were washed away, and they didn't even know the names of the medications, and they didn't have electronic health records so that we could trace them. So what public health, caregivers and public health agents were doing was taking around, big pictures of pills and asking people, is this the pill that you used to take for your diabetes, right? So how do we even, things like that used to be our old public health emergency, and now we have this new system. On the other hand, if my government asks me to share my information and promises and is required by law to destroy all of that information in 3 months or 6 months, when we hope the pandemic is over, I might be more likely to share that information because it's not going to be there forever. You could analogize that idea to newborn blood spots from heel sticks, right? You're going to use it for these particular tests and then it's going to be destroyed, versus you're going to use it for the entirety of my newborn's lifetime and you're going to keep looking at it for whatever research you decide to use, right? So people might be more likely to use it, and that might be an interim solution until we figure out how to safeguard data more fully.
No, thanks, Melissa. And I think that's absolutely the case. It's a very, very complex situation. First, a reminder to all our participants that we are going to start winding down, about 5 minutes or so left. If you have any final thoughts, reflections, or questions, please put them on the chat board. And Ross, maybe for sort of a final question to you around what I think might be possible in terms of the technology itself, because that's where you started with. How can the technology itself allow you the opportunity to increase safeguards and to reduce misuse, right? So it's one of those things that we really haven't thought through very well, but are there ways in which your committee, particularly your global committee at WHO, has been thinking about this?
So I would say not so much from the committee's point of view, but in other work, yes. Technology has that wonderful Janus-faced quality that it could be as much empowering as it could be sort of imprisoning. And I think really for public health, because public health is probably the most data-driven aspect of health systems, that if we can win the hearts and minds of our communities to recognize that they have an investment, that we're all in this together, not just in the COVID, but for prevention, health promotion, and that being able to access data is the very foundation on which we've built, all of our prevention programs, all of our community health profiles. It's how we know where there are problems. I think somebody was worried about issues around bias. If we're recognizing structural cause issues and actually have community stakeholder involvement in the measurement and the management of that data, then we can actually start to use these new technologies in ways that would be health enhancing, rather than on the distrust side, just mere vehicles for basically strip mining economic value out of personal health information. So my fear is the strip mining side. The possibility is actually truly using data to enable communities to be resilient and thrive and achieve optimal health.
Thank you very much, Ross. And Melissa, maybe as a final question to you, concerns around variations, both in terms of processes and in terms of the quality of the data, right? So not only did you identify that local, state, and federal governments have different responsibilities, we in the US have just had an amazing model. We had trust in an organization called the CDC, and data was going there, and now suddenly it's going somewhere else. But then also there is no standardization, as pointed out in the chat board. So maybe a final reflection on, from you on these types of issues that will affect our concerns around this issue of digital privacy.
So there is constant work at the government level and in private industry on interoperable standards, standards development, trying to get everybody to use the same standards for the data. One of the issues is that the large companies of electronic health records like Epic, Allscripts, there's one that begins with a C that I'm blanking on right now. The very big ones are very protective of their data. So this is where HHS focuses on the idea of data blocking and outlawing data blocking and having remedies for data blocking. The idea of standardization is very, very important for moving forward. At the local and state and federal levels, the data that is collected, we have always done things this way because of the system of government in the United States. And an important thing to remember is that community engagement means that things are going to change depending upon the will of that community, right? So if a particular community or tribe or a group of individuals has an issues of trust and wants to do things a different way, and you're engaging that community with how you're going to do things, to then say, we're going to ignore you and do it the same way that we do everything else, also has its problems. So standardization is not a panacea for all of our problems, because we are trying to engage different communities and earn their trust. It's a double-edged sword.
Ladies and gentlemen, this hour has been about discussing digital privacy in the context of, sorry, Ross, did you want to come in on that?
No, I just said that's about the fastest hour I've experienced recently. That was great, thank you.
And before I truly thank our panelists, I want to remind folks that we heard today about the powerful role of technology and some of the ethical issues that that can create, while we understand the importance of technology in helping us, particularly in addressing concerns and particularly our public health response to pandemics like COVID-19. We've also been reminded of things which in a rubric way can be called the fair information principles, but that are generally fair principles in discussing some of these issues. We've talked about trust, again, as a key element about handling this issue. And very importantly, about this notion of what will the data be used for and by whom. But I'm really happy that we've also given suggestions about how it might work, about this notion of commissioners or independent panels, about this notion what international organizations may provide some guidance to us on this topic. I think this is an area where I think it would be fair for me to say that there is no teacher and there is no learner. All countries are teaching and learning each other at the same time. So I don't want there to be an assumption that, you know, high-income countries have something to share with LMICs and so on. I don't think that exists in this space. I think, in fact, that the most innovative models may come from some of the more resource-constrained countries. With that, I want you to join me in thanking Professors Upshur and Goldstein for sharing their thoughts with us, for being available to us. Both had very interesting and insightful analysis of this situation. I want to thank my GW team, Michelle, Hina, Lauren, and others who support this enterprise. I want to remind you that in 2 weeks' time, our 10th webinar will be on looking at ethics in COVID-19 from a global perspective. And we've invited representatives from the World Health Organization and the Pan American Health Organizations to talk to us from a global perspective. Thank you all for joining us today. It's really wonderful to see so many of you come back on a bi-weekly basis. Thank you again, Ross and Melissa, for your participation. And I look forward to welcoming all of you in 2 weeks' time again. Thank you, folks. Be safe, be healthy, and be well. Bye-bye.
Thank you. It's a great pleasure.
Much.
Bye-bye.